know the scapula can move in a whole bunch of different directions. It can move up, it can move down, it can move like the faces of clock, okay? We move at all different angles, so we have to restore scapular mobility somehow. So like I said, the scapula isn't a true joint, it kind of slides on the thoracic cage, you know, back there, okay? So the mobilizations are useful for obtaining full shoulder girt mobility and mechanics, okay? You're going to have the patient lying on their side, obviously, because I need to get to the scapula, okay? In the book, it shows that, you know, you stand in front of the patient. Sometimes I stand behind the patient, too, just because I've got short arms and it's hard for me to reach across them without sticking myself in their face, okay? So a lot of times I'll start behind them because I feel like I can position them better. Either way is fine. The book shows standing in front, okay? Sometimes it's better for the patient. You know, you're facing them, you understand them. So can you lay on your side facing me, please? Oh. Well, actually, is it easier if I do it this way so you guys can kind of see scapula? Okay, I'm sorry. Yes, go ahead. Let's lay it this way. Okay. Once again, I want to have their neck appropriately positioned, so I don't want his head like falling, you know, off here. So I usually have the head, you know, just in neutral, okay? Okay. So basically, I'm just restoring scapular thoracic mobility. So my stabilizing is my thorax. The thorax is just kind of stabilized. It doesn't really go anywhere, so we don't have to stabilize it, okay? I'm going to mobilize the scapula in multiple directions, okay? So I can go inferior. I can kind of glide a little bit like, you know, this way to do like a distraction, like, you know, it'd be, instead of retraction, it'd be, you know, more like, you know, distraction away from there. I can push down this direction. Usually you don't need that one. Usually you need an inferior glide, you know, because I've usually got tight traps, you know, I'm going to be pinching up here, and you might need a little distraction, you know, so those are usually the two that, you know, they're going to require, okay? So I want to be, you know, if I think about how my scapula is positioned, I'm kind of up here like around the acromion, you know, up on this, you know, superior border here, kind of right by the acromion. So I'm going to put one hand there, that's kind of the top of my scapula, would we all agree? Mm-hmm. So I want to have one hand on the top to do the mobilization. I want to have one hand here underneath the scapula. He's got this really great one. I can cup right underneath it here, okay? Also recognize if the patient is really far forward here, the scapula comes against the thorax. So if you feel like you can't get your hands in here, well, maybe you need to move your patient back a little bit, okay? Does that all understand? Okay. So in the treatment, I usually have either their arm resting by their side here, comfortable on towel roll. It also shows where the patient, you can grab here. And I can be here, so I'm grabbing here at the acromion with one hand, you know, like here, and then I can kind of grab underneath the scapula here with the other hand. Okay? So I'm kind of here. Can I get here? See how I can push here at the acromion? I can push here up. So I can just do this.
Is your left hand on it?
The left hand is on the scapular inferior border. Okay? Okay? So I would be at the inferior border of the scapula. If I want to do more of a, you know, up, you know, it would be like this direction. If I want to do more of that, you know, opposite of retraction, if I'm kind of like distracting it here, I can cup right underneath here. He's got a really great shoulder blade. He's got winging here, majorly going on. So I can get right underneath here, and I can get in there, and I can just come straight this direction.
On that interior.
Okay, and really kind of get in there and get some traction in there.
But
Does that
you
make
said
sense?
too, you could do it on either side of him.
I could stand in front of him as well and
Okay.
reach over and glide there.
So I know that book shows that
the book
example.
shows, like I said, the book
Example.
shows in front of them. Sometimes it's nicer for the patient. You're facing them. You can watch their face communicate a little bit better. I'm
Can I
sure
make a
you
point
hear.
about that. If you're going to go in front, remember that in order for me to reach over him, I'm sort of putting my naughty bits in his face.
Yeah,
So-
that's what I was talking about. That's why I don't do it so much because
And
yeah.
if it's a lady, we've got her chest there. So what we want to do is put a pillow here, so that if I'm leaning into him, I'm not pressing into their chest. A little separation between us and them. So if you're coming from the front, not Joe, we're all adults, right? Get that pillow there, so when we're draping over, we're not making contact.
Not necessarily.
Right? Yeah, exactly. Does that make sense? So we come from the front, separate yourselves with a pillow.
Is the prone position anyway appropriate?
Usually not very well because kind of like my scapula, you know, is kind of like, remember, it's stabilized that way a little bit, so it's a little bit hard for me to especially distract.
For
You know,
someone
your
who's
arm
not able
down.
to lay
Yeah,
down
and then
this way?
honestly, remember what I said? How the arm has to be a little bit behind the plane of the body for that scapula to come up? So usually I would have to hold the arm up then, and then how do I hold the arm with one hand and try and glide the scapula with both my hands? I'm not an octopus, okay? So,
Can I show one other option?
yeah.
One other treatment option. So the one thing I want you guys to feel is scapular elevation, depression, protraction, and retraction. The way I do it, can you scoot forward a little bit? I'm a wee man, so I need to get myself in a position where I have some leverage. I'll come here and cradle this arm this way. And you can put a pillow between yourself here, but I'll hold like this, and I can hold their arm like that, it's fully supported. Then this hand can come and grab that scapula here, and I can hold his inferior angle if I want. And I can take the scapula, and I've got free rein. I can elevate his scapula, I can depress it, I can retract it, or I can protract it. Can you see how I can passively move his scapula in all ranges here? And his arm is well supported, and I'm moving all over, and I can feel that inferior angle. If I want to mobilize like we were talking about and distract, I can get here and distract that way. Okay, if we've got a stuck one. But I can hold this scapula, and he's very relaxed. His thoracic cage isn't moving. If I can retract, protract, elevate, depress. You need to be able to feel all those motions. So we feel a bunch of normal scapulas, and we get one that doesn't move the appropriate way, we'll know it needs to be mobilized. So today, a lot of normal scapula. Get your hands on there in whatever way you see fit, and let's feel the elevation, depression, protraction, retraction. Let's find those motions and feel those motions.
Could you show how the mobilization looks like? You just show the movement, but how the mobilization?
No, do the movement. Which one? Which mobilization?
He just shows you what we want
So
you to do.
Yes,
basically,
but
if you
like
do those ranges.
Like you're doing the like a 1, 2, 3, 4.
Okay, so what I would do is
It's
that
not
if
really
he
a
doesn't have any
great
restrictions, so he doesn't need to be mobilized, but let's just say his scapula will not depress, I would come to the end of what's available. So here's where you're at. I would start, if I was going grade 1, I would kind of do oscillations here.
Okay.
Grade 2, I would go from here to the middle of the available range. 1, 2, 3, and then back. Grade 3, I go to the end of what's available, as far inferior as I can go, the biggest inferior glide I can make. And I'm going to sit here, 1, 2, 3, and then I'm going to come back. And then my grade 4, I'm going to come way to the end and oscillate. To be honest with you, this is not a very normal motion. What I want, you don't, that's not the most normal mobilization. And then I can retract him, same thing. So this is weird because in the shoulder joint, glenohumeral joint, there's very little translation, right? You couldn't tell a lot of movement between a grade 1 and a grade 4. But with this, you see his scapula travels like 6 inches from up here to down there. That's a lot of travel, but that's how much play that joint has. So the beginning of his available range of motion is there. The end is way down there. So that's a lot of movement of that scapula. Does it make sense?
Yeah.
So feel the motion, feel what's available, take them through the available, technically arthrokinematic. I mean, it's not really a normal joint, but feel how much it can move. And then when you get an abnormal one, we would do our 1s, 2s, 3s, and 4s at the end of whatever the available ranges are beginning, depending on
And
what
is this
grade
your
we're doing.
typical body position here?
That's
when
me.
you're
This
gonna-
is how I
That's
do
you.
it. The book shows you here, or it shows you
Yeah,
here.
In front,
And
actually,
it shows him
yeah.
cradling the arm.
I'm sorry. And then, again, we got a little pillow here, and we can come here, and I can cradle. I got top and inferior angle, and I can do it this way. Again, with a pillow. Makes it, this is what the book shows, I believe.
Yeah.
Or they may show this.
Any way in lab is okay as long as we
If you have
an
control, they're
understanding
relaxed
of
and
what we're
comfortable,
doing.
and you're
And
not
I can
pressing
see it
things
move.
against him inappropriately, then I think I'm okay.
Okay.
Let's try it. Let's feel the movements. Elevation, depression, protraction,